I always used to tell my team at HHS, lead with the need. Another way to kind of look at this is, how can I help solve a business problem at HHS or one of the agencies at HHS, but also make it durable so that if priorities change a little bit, my technology, my product, or my service can be put to use, even though maybe the priorities have shifted on the thing for which my product or service was actually originally purchased.
It is the duty of leaders to lead, of the creative to create, of the daring to do. The free world expects leadership of us. Its fate and our fate depends upon our leadership. We are industrious, inventive, restless, with the fires that burn within us. But I say that nothing is easy, and the best things are the hardest. And all our troubles, all our immense difficulties, now and in the future, can I say, be solved if we have the will, the courage.
Welcome to this StartUpHealth Fireside Chat. I'm Logan Plaster. I'll be your host for the next hour. I'm the media director and editor-in-chief here at StartUpHealth. It's my pleasure to get to host these Fireside Chats. Today, our esteemed guest is Ed Simcox. Ed is the former Chief Technology Officer, the CTO of the U.S. Department of Health and Human Services. He's currently the Chief Strategy Officer at LifeOmic. Ed has brought his wisdom to the Startup Health Festival stage before, and we are pleased to have his insights again today. So Ed, thank you for joining us in this Fireside Chat.
Thanks for having me.
Awesome. So let's start with a bit of your story. You've got that big title, the CTO of HHS, and I'm sure people are curious kind of how you got into that role. Tell us briefly how you came to be the CTO of Health and Human Services, and what's one or two things people probably don't realize about working in that regard.
Sure. So I've been in health IT and health tech almost my entire career. Studied to be an attorney, never really practiced law, but got into startups and started companies, two of which have nothing to do with healthcare. One was a satellite imagery company, and another one was a back office process automation and workflow type of an application. And then got into healthcare in a pretty big way, designed a piece of software with a couple other people that was meant to automate the patient throughput inside of operating rooms and operating suites. So, from the moment the patient walks in the door, through the pre-op process where you do pre-op antibiotics, et cetera, intra-op stuff, post-op things, with a red, green, yellow metaphor, dashboard for the nurse's station. And the whole idea here is that time is money and time is safety when it comes to operating rooms. And so those were really the two things that we focused on with that app. We partnered with Microsoft, and they actually gave us a free license to their Outlook metaphor. So it looked and felt a lot like Outlook. So that was really my first foray into healthcare. And then I became a CTO at Indiana University Health System, which is 18 hospital system, and has a level 1 trauma center, an acute children's hospital, and many other specialty hospitals. I worked for AT&T after that and did product marketing management, and then owned basically half of the product portfolio for healthcare products that AT&T had, as well as services. So telehealth, mHealth, health information exchange products and services, and a couple other ancillary things. And then I went to another IT company called Logicalis. It's an international company, and where I focused on starting a healthcare practice, a healthcare IT consulting practice. And we worked with large OEMs and small software vendors, all pretty much across the spectrum of size, to create custom solutions primarily for providers, hospital systems. And that's where I really was able to lock in and understand how leadership inside of hospital systems, as well as in primary care practices, think, and the problems that they were facing around data. The problems they were facing around data were immense. It was very difficult to get data out of their own systems, namely their electronic health record systems. It was hard to get data in and out of ancillary systems as well. There was really not a lot of standardization there. I mean, we had things like CDAs and HL7, but it really didn't cover enough of the gamut of data, data movement, data liquidity, data transformation that was necessary to really stimulate startups, to stimulate innovation. And I was asked to come by folks that had served at HHS before. I was asked to come to HHS and thought about it for quite a while and decided that I really did want to do this. And I wanted to go for two reasons. Really, one of the reasons was I wanted to really throw my weight behind, or my support behind, data liquidity, data democratization, the freeing and liberating of data across the healthcare ecosystem. And number two, frankly, I had a mentor who had served 2 tours of duty within HHS that said, you know, you really have to go do this. You think you may know healthcare pretty well. You've been in it for quite a while, but you don't know the half of it. You have to go and understand how regulators think, how policy is made, how Congress thinks, and how that is expressed in legislation, and then the drop-down regulations that sit under that legislation. And he couldn't have been more right. I find that every single day in my professional life, I rely on the information that I gleaned from being in this role, and just an amazing experience.
Your professional career, really took you through a series of roles required you to innovate. You started out very entrepreneurial, and then you started these divisions, these health divisions within other companies, big tech companies. And then you come to HHS. What was the state of innovation in the federal agency when you got there? Obviously, you wanted to innovate, you wanted to change, you wanted to develop. But talk to us about sort of the state of the innovation mindset in HHS.
The state of innovation, as far as the CTO's office, was actually really good. And I'll tell you why. Under the Obama administration, starting with Todd Park, and then followed by Brian Civic and Susanna Fox. Those are my predecessors. I know you've worked with Todd, and you've had Todd speak to your groups before. I was able to kind of stand on the shoulders of giants. The innovation that the creative disruption and innovation that Todd, in a very brash, unabashed way, was able to kind of push into HHS is very remarkable if you look at the history there. And there were other parts of federal government that benefited from Todd, as well as other parts of the Obama White House, really leaning into creative disruption and innovation, and also this idea of the intersection between private industry, as we say in government, and the public sector. And there are multiple programs that were started and continue to this day. Government on its own doesn't innovate. There are pockets of innovation that we can look at, like BARDA, if you've heard of BARDA, DARPA, right? Things like that. But by and large, there are 80,000 people across HHS. There are 29 agencies and offices at HHS. And there's not a lot of, I would say, native innovation, or there wasn't, right? So Todd and the rest of the CTO posse, our remit, our job was to promote this innovation and also really connect with the private sector. Like I said, there are other examples of this innovation too, like the U.S. Digital Service. And this is the idea where, people from private industry come into federal government, do a tour of duty to help solve pressing problems. And this really came out of the work that Todd and other people did to fix the healthcare.gov system that kind of crashed and burned in its initial iteration. And through the use of, bringing folks in who knew how to do agile development instead of cascade or waterfall development, and people that understood cloud, people that understood things that we kind of take for granted in the private sector, but are kind of rare still in government. That was really the key to turning around that project. And those types of tools are extremely valuable within government.
Let's talk a bit about the state of health data at the federal level. I mean, you were steeped in health data in the private industry before HHS, and then you said your mentor said you don't know the half of it. So you really got schooled in kind of where the federal government was at in terms of managing health data. So kind of take us there. What was health data like at the federal level when you joined versus kind of where are we at now? Give us a little history lesson.
When I started, I was surprised that there wasn't more data sharing across federal government, but even within HHS, the HHS family. And we really have struggled over the years to share data and democratize data, free up that data, liberate that data, what we'd say interagency, intra-department. So HHS is a big department. Again, it has 29 agencies and offices. And unfortunately, these agencies, while they play nicely together kind of at the executive levels, the data stewards, as we call them, aren't necessarily geared toward sharing data. And there are a couple of reasons why that happens. One is that the folks are afraid that they may violate some sort of regulation and that they may get themselves in trouble if they share data and they don't track its usage after it has been shared. And we really didn't have the tools within federal government we didn't have modern data sharing platforms. We didn't have ways to track data, what we call data use agreements, which are these legally binding agreements between agencies that really create the four corners, the rules around data sharing between agencies. And the other reason, frankly, I think is because a lot of folks that have been in data for their entire career, and there's so many smart people across HHS that trade in data, that create data, that analyze data on a daily basis. There's a thought that data in the wrong hands can be used incorrectly and can cause harm. It can cause harm to public health. It could cause harm to patients, and it can cause unintended consequences when it comes to policy. So a lot of times people really want to chaperone that data or shepherd that data as part of the work that the secondary use work that would happen with that data. So what we did is we came in and said, let's figure out what we're working with here. Let's figure out why data isn't being shared. And I just told you, I think the top two reasons why it isn't. And then how can we put together an innovation program and maybe create a cloud-based solution to allow us to share that data more readily. And that's exactly what we did. So we took a phased approach and we went to all of the stakeholders in all of these agencies. And at first, the body language, that was given off by the folks we were talking to was kind of negative or protective, a lot of folded arms in meetings and things of that nature. And once we would ask a question like, do you have problems getting data from other agencies? Is it easy to do? I mean, would it be helpful for you to be able to get data? And it was just amazing. People would just open up and talk about the trials and tribulations of them getting data. And what that did is it started a great dialogue where they were able to kind of empathize with the other side, if you will. And then we would say, that's all we're trying to do is have this dialogue and then back this dialogue up and enhance it with a data platform. And so then we put an RFP out to create a modern cloud-based, agile-based data sharing and analytical platform to care for all of the regulatory issues, to care for the, like I say, people, process, technology in that order. And that's super important anytime you're doing like a big project, right? People, process, technology. So understand the people where they sit and understand what makes them tick, understand the processes under which they must operate, right? And from that will fall out what your technology should look like. And that's exactly what we did. And I'm happy that the platform that that I mentioned has been put into practice now. It went through what we call FedRAMP certification, and it's off to the races, doing things, all kinds of different things, including helping combat the ongoing opioid epidemic that we sometimes have kind of lost sight of simply because of COVID over the last year. But lots of great work going on in that platform now.
You mentioned on the Startup Health stage, I think a year and change ago, a staggering statistic that 1% of the federal budget goes towards dialysis treatment. That's more than the budget of NASA and the Department of Commerce combined, I believe you said. And you mentioned how little innovation has happened in that space in contrast to the amount that's being spent. And I think it's a kind of an interesting segue to talking about, where are there opportunities for startups to sort of meet some of these tech needs within the federal government, things that you witnessed firsthand at HHS?
Sure. So I'm kind of going back, I always used to tell my team at HHS, lead with the need. So look at where there's a need. So just because we have a cool technology doesn't necessarily mean it's needed by a particular customer or particular customer base or sector, right? So figure out, if you already have a technology, figure out how to match it to the needs of the agencies at HHS. And this is where Dr. Google comes in really handy. A lot of this stuff is very public and forward as far as, everything from the regulation and the policy, which drive a lot of the work down in the agencies, to actually the work product that's coming out from the agencies, and then RFIs and RFPs and different purchase vehicles that are being published by the federal government. All of that stuff will help, indicate where the priorities are. And those priorities change over time, right? So another way to kind of look at this is, how can I help solve a business problem at HHS or one of the agencies at HHS, but also make it durable so that if priorities change a little bit, my technology, my product, or my service can be put to use, even though maybe the priorities have shifted on the thing for which my product or service was actually originally purchased.
What are some of those areas of opportunity that you've seen beyond dialysis as sort of a first example?
So a lot of them are really well aligned with the moonshots of Startup Health, actually. What I'll give you some of the macro trends that I saw during the last 4 years, and these will continue to be big issues. And then we can maybe hit on some that I think will be new to the Biden administration and will be kind of come to the fore, right? So number one, we talked about opioids. I would say we still have an opioid crisis in the United States. Some people would disagree with that, but I continue to see the data on this, and it's still a big deal. Very closely related to that is mental health. And we saw over the last year how important it is to provide mental health services and do it with the support of technologies. That's going to continue to be a big deal over the next 4 years. Telehealth has definitely come to the fore. I was on the board of the American Telemedicine Association a few years ago. I've followed telemedicine and telehealth very closely. We're finally turning the corner now around telemedicine and virtual care and digital care to where it's becoming more commonplace. And I think probably in the next 4 or 5 years, we're going to drop the name telehealth or telemedicine, and we're just going to call it medicine. And it just happens to be, it's like, I'm going to do some banking. Doesn't mean I'm going to the bank. I'm actually going online, or I'm going on my smartphone. So we're probably going to see that critical mass where the digital side of health, of rendering healthcare, is actually the predominant form of it. And that is very, very exciting to me. Watch very closely, by the way, what CMS does and what Congress does over the next 12-month period around reimbursement, because obviously we have to get paid. Our clients or our customers have to get paid for the use of our technologies. And we're seeing a real loosening up of the rules around reimbursing for telehealth rendered services. And that's very exciting to see. And I think that that's going to continue. During COVID, CMS actually really loosened some things up, but did it in a temporary way. But there's a push within Washington to make a lot of those temporary changes permanent. And people are realizing, hey, there's no reason why we shouldn't be doing this. And that leads me to another trend, and that's around health equity and social determinants of health. And the reason I segue is because telehealth is super important, and digital health technologies are super important to bridging gaps in health equity, whether they're geographic gaps, whether they're demographic gaps, whether they're ethnic gaps. And we'll continue to see a pushing forward of this idea that technology can really help in circumstances like that. Yeah. In fact, right now, there's a bill in front of Congress around the Indian Health Service, which I did a lot of work with when I was in DC. And there's a huge disparity regarding healthcare for tribal nations and native lands and folks that live there. And I'm happy to say there are technologies that can really help. It's just a matter of making it a priority, right? So those are just a smattering of things.
Those themes, you mentioned those like align with our health moonshots. Those themes resonate with, I'm sure, every founder on this call. And I think where it gets really interesting is kind of where the rubber meets the road, how a startup addressing some of these themes really begins to collaborate with the federal government. And so I wonder, if you're thinking strategically, you mentioned BARDA, you mentioned another program. I wonder if we could kind of spell out a couple of those just as really clear tools, ways that you can actually bridge that gap. What was the second one you mentioned?
Yeah, so BARDA, I have to actually look up what it stands for, but I know it very well. But actually, one of my former colleagues, employees in the office of the CTO is now a director in BARDA, and his name is Sandeep Patel. And BARDA stands for Biomedical Advanced Research and Development Authority. That's a very governmentish sounding thing. But BARDA is one of a few places within HHS that has the authority to kind of hack the way that we acquire technologies and innovations in federal government. And the office of the CTO is another place. And I think what I might do is just walk through some examples of ways that people can hack through the traditional acquisition process at HHS.
Love it.
So there are these things that are, they're called purchase authorities that a lot of folks don't even know about. And one is prize competitions. So you had, when I last addressed the group during JPM, we talked about KidneyX, right? So you can check it out at kidneyx.org. And it's KidneyX is a prize competition. So think the X Prize Foundation, right? So looking at pressing problems that are really crying out for innovation, but for whatever reason, the innovation hasn't really surfaced. And the market hasn't brought that innovation forward. And in this case, the innovation hadn't been brought forward. And the primary reason was because the way the federal government pays for dialysis and related treatments. And people that were coming out with these amazing innovations just couldn't find a way to get into the market and get paid for their stuff. And so it was stifled. So anyway, we applied this idea of a challenge combined with a prize competition. And we gave out, and they are still giving out. I'm no longer working with them, but they're still giving out non-dilutive funding. There are 2 or 3 active prizes going on right now that you can see if you go out to the website. So that's one thing that we really wanted to harness in the office of the CTO and really promote across HHS. And I think you'll see that carry on. We did one on Lyme disease. That's another area that is really crying out for help in a big way, and then a whole host of other ones. So that's one thing. Then there's this idea of a cooperative agreement, which is similar to a grant. So some of the folks on the call may have gone through the SBIR grant program.
Sure.
I won't unpack all that right now, but you can Google it and learn that the NIH and other components within HHS have this small business grant program. The idea of a cooperative agreement is a little different. It actually affords more flexibility in the way a program is set up. The idea is, instead of doing an arm's length where you just give money to an innovator and hope for results, in the case of a cooperative agreement, there's an expectation that the government is actually sitting there helping develop the solution and helping in a very, very cooperative way, sitting side by side, come out with solutions to pressing problems.
Gotcha.
That's a relatively, that's been around for a very long time. I think since 1983, but has just really surfaced as a tool that can be used for federal government to reach out to industry.
Interesting. It feels as though, and you can correct me if I'm wrong, it feels as though COVID has brought some of these programs to the fore, brought more attention to the ability to, apply to one of these competitions, SBIRs. There's some energy behind this.
Absolutely. Don't forget, there are individual ways to do this too. So there are these opportunities to be a presidential fellow, to be an entrepreneur in residence, to be an innovator in residence. When I was CTO, we brought people and embedded them inside the CDC to do some, I think, simple blocking and tackling around cloud. So we wanted to see the CDC, I was also the acting CIO at HHS. So I had to report back to Congress and the Government Accountability Office as to our shift to the cloud. So all agencies have to move to the cloud. And the CDC was having a really tough time doing it because of the technical debt inside the organization. They couldn't hire folks that understood microservices and serverless computing and agile development and things of that nature. It was very difficult for them to pull them off the street and pay them right and get them in there. So we brought one person in there as an entrepreneur in residence who spent, I think, 18 months there, and just mind-blowing amount of transformation in that amount of time. Just unbelievable. Lifted and shifted certain apps into the cloud, and then others were refactored and rewritten to the cloud. And then some apps were retired in favor of cloud native apps, right? So kind of three-prong approach there, all within a period of 18 months and a very small team of people at the end of the day, probably 4 or 5 people.
I want to learn more about what you're doing now with LifeOmic, but before we do that, get to a couple questions in the chat. Sure. So Jenny Gallagher from Helpful, let's start with you. Come off mute.
Ed, thank you. This is terrific. So my question had to do with, you discussed up front just, your passion around accessibility of data. And then you were talking about some of the priorities, which included mental health. And I'm wondering, this is maybe sort of uninformed on my part, but I'm wondering the extent to which, a government department like HHS focuses more downstream in terms of the data, the evidence shows that there's a problem. Let's come up with solutions to address the problem. So, for example, treating mental health versus solutions that get upstream to try and avoid issues that are preventable, such as loneliness and social isolation. And I know that there is some data around that, but they're harder, they're harder to measure and quantify. So I'm curious about that in terms of, generally, is there a bias towards, we need to know that without, it's irrefutable that how do we solve this problem, this particular problem, versus trying to get upstream of root cause?
So great question. There are 2 ways that HHS goes at problems. One is they're told to by Congress, and they're given money by Congress to go solve a problem. So there may not be data Congress may enact legislation just around mere anecdote, right? Like one or two really well-known bad things happen, sentinel events, if you will, happen. And then money is given to HHS, and HHS is instructed to go solve an issue. And in that capacity, HHS reports to Congress and is accountable to Congress, right? Then there's another thing that has to do with the mission of an agency. So Congress, a lot of the work happens to support the mission of HHS and its agencies, and that's ongoing work. And that's where a lot of times HHS will partner with industry to get data on things such as what you're talking about. They will, and sometimes they'll collect it directly. And in the case, I'm very familiar with this idea of aging in place. So instead of putting folks that are aging or disabled in skilled nursing facilities or other types of institutions, let's equip their homes with technology, ramps, hot meals delivered and things of that nature, so they can be independent and live out in their communities, right? This has been something that's gone on for 30 years. And there are a couple agencies that work on this. And what I would say is the data is there. The other thing I'll say, though, that the social side of HHS, there's the medical and healthcare side and the social side. They're really two separate universes, and they're starting to come together. And Dr. Donald Rucker, who is the head of ONC, actually did a lot of work to promote this idea that we want to see more standardization and liberation of data over in social services, because it's all very piecemeal and it's very disparate and disconnected data. And we thought it was bad over in healthcare. You should see it in social services. This idea of moving upstream and being preventative really requires us to be data-driven, and really requires us to be science and evidence and data-driven. And so we need to do a lot around that. And then once we have started to do that, and we have, you can begin to answer questions about what does isolation do to one's mental health? What does isolation do to one's physical health as a result of issues with their mental health, and so on? And social determinants of health, as you're probably aware, is an extremely data-driven pursuit, almost by definition, right? The determinants part of this is super important. We have to get the data right on it. We can't solution by anecdote. We can't lead by anecdote.
So we've talked mostly about your experience at HHS, how startups can work with the federal government, but you transitioned into startup life yourself. I mean, you did it before, obviously, but you were the chief strategy officer at LifeOmic. Give us a glimpse of what LifeOmic is, what you're building there.
Sure. So I left Washington on February 14th of last year, and started my new job 2 days later. And so what LifeOmic is a precision health company. And what is a precision health company? For us, what it means is that we have built a AWS-based cloud platform that and a very, very sophisticated data lake with sophisticated APIs and interfaces to all kinds of data. And the whole idea for us initially was to bring different types of data into our cloud platform to help do a better job of diagnosing and treating cancer. So think whole genome sequences, think SNPs of genomes, think the genotypic data associated with particular types of tumors, which is super important. I didn't realize this. I'm not a genomic guy by training or anything, but if you don't understand the tumor of origin, as they say, so let's say you have a scan and they see a tumor, just because it's, say, in your shoulder doesn't necessarily mean that it originated there, right? It could have metastasized, it could have migrated, those types of things. So we now have the ability to actually look at the DNA of that tumor and not just take a guess of where it originated from, but actually tell. where it originated. And that is super important because it helps typify the tumor, and then the docs can then apply the right biologics and the right chemotherapy to hopefully eradicate the cancer, right? You'd be surprised at a lot of the guesswork that goes on in oncology. And so our whole reason for doing what we did was that. What the other thing people don't realize is that oncologists are super highly trained and highly technical, but they don't know how to put genomic data to use in their practice. So what we really built this platform to do was take an extremely complex process and to apply AI and machine learning to this problem, and then allow what I might call a medical layperson, i.e. an oncologist, to understand the super technical nature of the genomic data to solve problems in clinic, right? So that's the first thing we did. And in the process of doing that, we very, very quickly realized that not only is it important, to diagnose and treat cancer, but even more important in a lot of cases is what happens after chemotherapy and radiation, right? And that's where recovery comes in, and having a healthy life, post treatment in remission. And so what we did is decided we had some aha moments. I've done a lot of work in wellness and in a whole person health and integrative medicine and things like that. And we decided to create a couple apps, and we decided to go direct to consumer with these apps. And the whole idea was to take this idea of precision and being data driven and apply it to something that for a long time hasn't been very data driven, and that's wellness and longevity. So we created two apps. One is a fasting app, an intermittent fasting app, and one is basically the 5 pillars of health, and put them out in the app stores just to gauge interest and hopefully learn from our users. And I'm happy to say we have over 3 million users now of our apps. And as far as active users, folks that are in the apps every day, we have 300,000 users. We're getting millions of data points a day back from our users. And what we're doing is going back and doing A/B testing, figure out how we keep people engaged in the apps, figure out how to keep people on the track to being healthy and really owning their health status and improving their health status. So often what we find in healthcare in the United States is people feel helpless. They feel like healthcare is done to them, right? Instead of with them and for them. And so the whole reason we put these out was to say, healthcare is really not that complex if you take a preventative and a wellness approach to it and you move upstream and you really try and impact health status, then it becomes healthcare instead of sick care, which is what we're all used to. So those are really the two sides of our business. We don't generate revenue off the two apps that I just told you about. But what we have done after we've learned from this data is we've come out with two commercial versions of those apps. One is a personal wellness app that we call Precision Wellness. And the other one is a corporate wellness app. And the whole idea here is to go out and talk to providers about, hey, you're shifting to value-based care now instead of fee-for-service. So we want to start paying for quality instead of quantity of services rendered, by a hospital, a provider, et cetera. And we feel that we have a way to reach patients, especially in the value-based care setting, that nobody else has. And we have the data and we understand now how to really move the needle on health status and wellness in a very big way and in a very inexpensive way.
We have time for one more question from Ismail from Innovarex. Sorry. Ismail, if you could come off mute, that'd be great.
Yeah, excellent. Ed, thank you so much. This has been a wealth of knowledge. Just from a healthcare provider standpoint, I'm a trained pharmacist.
Okay.
I'm always curious when it comes to like the fast adaptation of data, telehealth, what that does from a government standpoint when it comes to reimbursements and stratification of healthcare providers. Being that you were in the HHS, what's your sense on how it's going to change the industry in terms of how people provide care across, I guess, all fields?
It is there. If there's one technology that I think, or category of technology in our industry that is the game changer, it's telehealth. It has the ability to erase boundaries. It has the ability to create immediacy where it can't exist otherwise. It has the ability to create digital audit trails and pathways of data that no other technology has. It is so highly pervasive now because we all have smartphones that can do 4K selfie video. Not all of us yet with selfie video, but very, very close, right? So we're talking high fidelity, quote, medical grade, not FDA certified medical grade, but you understand medical grade interactions to the point where dermatologists would rather see an image coming across a smartphone than put in their loop over their eye and looking at it in physical space. It's kind of, it blows my mind. My point is that it is the game changer, right? To the point where I think it's going to really push where the tech. This is an example of where technology definitely is pushing the envelope. People are starting to ask, why can I use my phone for everything else in my life, but I can't for this really important thing called healthcare, and my prices keep going up on healthcare. I can't get in to see people. This doctor's willing to see me across the state line, but I can't see them unless I drive an hour and a half. What is up with that? And when we talk about health equity, it is the biggest thing, right? It's the biggest thing to break down these barriers of health equity, because it doesn't matter where you are. If you have a rare disease and you want to see somebody at UPMC and you live in California, you can do it, right? But there are things that have to catch up. So the state laws have to catch up, and those are around medical licensing and as well as licensure reciprocity, right? And then the private payers have to catch up and say, yes, we're going to pay for this. We're going to pay for care when it is done this way. And then CMS has to catch up because they also pay for care, and a lot of the care that's rendered via telehealth. And of course, there are other payers too, like the VA, DOD, Indian Health Service, and so on. But it's I don't know if I answered your question exactly.
You did,
right, but,
you did.
Yeah.
Precisely. Yeah, you did.
Yeah.
If we had more, I love what you're emphasizing, Ed, with the power of telemedicine. If we had more time, we could hear all about what Ismail is doing in Gambia using telemedicine. So many awesome global applications as well as domestic. So I think I speak for everybody when I say thank you so much for taking an hour out of your schedule, sharing a lot of high level wisdom, but also some very practical suggestions on how startups can get involved at the federal level and make a difference. So Ed, thank you so much.